Welcome, everyone. Thank you for joining us for today's webinar. My name is Fangfang Chen, and I'm the Clinical Manager for Respiratory Care at Philips APAC. This webinar will discuss how to select the right ventilator, algorithm, and the patient interface for optimal performance by Professor Cesare Gregoretti from Italy. Dr. Javier Sayas Catalan from Spain will present non-invasive ventilation, high-flow therapy setup, monitoring, and titration for acute respiratory failure. Now, without further ado, we will turn over to our first speaker, Professor Cesare Gregoretti. Professor Gregoretti is from the Department of Surgical, Oncological, and Oral Science, University of Palermo. He's the director of ICU G. Giglio Institute, Cefalù, Italy.
Good afternoon, everybody. My name is Cesare Gregoretti. I'm coming from the University of Palermo. I'm directing a university institution here in Cefalù, Sicily. So the aim of my talk is to talk to you about something more than just non-invasive ventilation. So I want to talk to you how to choose, how to select the right ventilator, the right algorithm, and the right patient interface, and maybe something more in order to optimize the performance of our treatment. This is my faculty disclosure, and this is my agenda. I want to start with some word about the background. As you know, when you are using a ventilator, a turbine-driven ventilator, for example, or even some ICU ventilator, you can have to deal with three kind of circuits. The common one is a double limb circuit. This is a normal circuit of ICU ventilator. Then we can have another ventilator, another circuits like the V60 ventilator. This is called intentional leak or vented circuits. And there is no valve. Usually we have a whisper swivel on the circuit, or we have a mask that is usually named vented mask. And the vented mask, as opposite to the non-vented mask, has some small slot or holes in the interface. Then we have another circuit. I can tell you that these circuits have a small market right now, but in the home care, usually some physician is still using it, is a one-way single limb with a so-called mushroom valve. So these two circuits have valve, and this circuit has not valve. So what's the major technical issue between vented and non-vented configuration? Anyway, during non-invasive ventilation, the likelihood of an intentional leak is very high. What I mean for intentional leaks, both intentional leak from the, for example, a vented mask, and unintentional leaks from the mouth during nasal ventilation, just to make an example. In addition, the performance or the ventilation expressed usually by the rise time may not meet patient demand, and I'm going to see how to detect this performance. Triggering of the ventilator may be difficult, or auto-triggering may occur. Definition of auto-triggering usually is an inadvertent triggering during normal ventilation. You think the patient is trying to take some breath from the ventilator, but really the patient is not triggering. And in addition, for the people, for the physician that are going to deal with children, few home care ventilators can couple with children mechanics. This is regard all ventilator, both vented and non-vented ventilator. So I told you about ventilator performance. Please have a look on the picture on the right. You can see that this is an old BiPAP turbine-driven ventilator in 1996. And this on the right side of this picture, you have a ventilator that was an ICU ARM 25 ventilator. That means that this ventilator was driven by compressed air. You can see that for the same pressure applied to the respiratory system that was about 20, you can see that the effort that was performed by the patient was different between the left and the right. So much effort with the turbine-driven compared to the ICU-driven ventilator. We can go to see to the flow between the turbine-driven ventilator and the ICU ventilator. You see a much more sharp wave of the flow for the ICU ventilator. Even the pressure was the same, but you can also see that the pressure in the ICU ventilator was a square pressure, while in the right part of the picture, in the turbine-driven ventilator, the pressure was not shaped. What does it mean switching to the left part of the picture as indicated by the blue arrow? Usually, a performance of a ventilator can be measured by taking account the 300 millisecond and 500 millisecond. So that means that during this time, the patient should be assisted. Why 500 milliseconds? Try to think a patient that is breathing at 30 of respiratory rates. If a patient is breathing at 30 respiratory rates, the patient neural time is about 600 milliseconds. So if my ventilator is not able to assist the patient in 500 milliseconds, that means that the patient is going to the right and the ventilator is going to the left. And I'm going to under-assist my ventilator. So the performance of the ventilator are very important. Time passed by over the time, and I can tell you that right now in 2021, the performance of the turbine-driven ventilator are comparable to the ICU ventilator, sometimes better. So what the other measure taken in issue, especially with ventilator with valve, I mean as a double limb circuits of the ICU ventilator. Non-vented ventilator may fail to measure tidal volume. So in presence of intentional leak, the displayed inspiratory tidal volume is higher while the expiratory tidal volume is lower. And we will going to explain this in details in the first slides. In addition, we have another very important issue that expiratory valves may increase work of breathing. I'm also going to explain what was the reason that led a great market for the old respiratory vision turbine-driven ventilator in the 90s, in the first year of this new century. The reason was because BiPAP Vision as a V60 ventilator has no valve. Start to address some of the questions I wanted to reply to you with volume measurement. Tidal volume can be estimated during NIV or can be measured. I can tell you that in ventilators that have a valve at the double ventilatory circuit, usually the tidal volume is measured with a pneumotachograph, with a flow sensor, with a differential pressure transducer. So flow is measured as a difference of pressure on resistances, and tidal volume is computed as a flow over the time. What does it mean? Does it mean that even is generally thought that tidal volume is perfect during measurement with a pneumotachograph? This nice paper published in 2010 by the Liaziti group in intensive care medicine clearly show, as you can see in the dotted and red line, that what the physician was set on the ventilator was different from what was really delivered to the patients. But remember this mathematical formula, because it will be very, very important when we'll discuss about leaks. So in vented circuit, tidal volume is not measured, but is estimated. And roughly how the ventilator is able, what is the algorithm in which a ventilator is able to compute tidal volume? Is quite simple. This is the flow that is coming out from the ventilator. This is a flow, the dotted blue line, that is measured by the ventilator as intentional leak. So what is coming out from the slot, from the hole, from the mask? Well, the ventilator is just subtracting the leaks, the intentional leaks that is coming out from the mask to compute the flow over the time, that is namely the tidal volume of the patient. Well, what's happened in case of non-intentional leaks? For example, leak from the mouth. Well, it doesn't matter because the ventilator knows very well what is amount of intentional leaks. So it's able to sense what is also the amount of the intentional leaks. Just to make an example, the ventilator knows perfectly that the intentional leaks was 25 liters per minute, 25, 25, 25. Now I have a non-intentional leaks, okay, in an advental leaks, so the ventilator is able to make a sum of intentional leaks plus unintentional leak, and subtracting the intentional leak plus non-intentional leak is able to estimate tidal volume in a quite pretty good way. This is a very nice paper by Lucian, published in 2013, but there is other paper published by the same author. You can browse the PubMed, you can find a lot of paper published by Manuel Lujan. And very interestingly, as you can see on the left part and the right part of the pictures, in the left part, you can see how the tidal volume is maintained with just big differences up to 45 liters per minute. And apart some condition as a patient with obstructive respiratory disorders, the tidal volume is very well estimated. So what about patient ventilator synchrony? Again, a very big problem during non-invasive ventilation. So we recently published this review, publishing respiratory case in 2020. And as you can see, how cyclone asynchrony can be also due to the ventilator characteristic, ventilator feature. And among the ventilator feature, you can also see expiratory valves technology. To explain well this concept, I have to come back to 1998, where for the first time, Lofazot, they was working with Roland Brochard at the time, was able to demonstrate that a mushroom valve, there was a valve of the single lip circuits with an expiratory valve. Well, the increase in expiratory time constant during this expiratory valve could lead to patient hyperinflation and so an increase of work of breathing. But you can tell me it was 98, a lot of time ago. But we go to this paper published in 2009, maybe more than 10 years later. And this study was conducted again by the group of Laurent Brochard. And as you can see, even in ICU ventilator, so we are speaking of a very powerful ventilator, when the patient is breathing with a low respiratory time, 1.5 seconds, that meaning breathing at 30 of respiratory rate, or even breathing in children, for example, at 60 of respiratory rate, the amount of trapped volume due to the valve can reach up to 40%. So valve can anytime, even in ICU ventilator, can increase absolutely the expiratory time constant, increasing the inspiratory work of breathing. And this is the reason, because in this paper, again, the group of Lambroschard 2012, they went to compare valve ventilator, ICU ventilator, compared to the old Vision. I can't tell you the name because the Vision was no longer in production, but it doesn't matter. Well, in terms of asynchrony, even the ventilator was very old because the Vision was very old. In terms of performance in patient ventilator synchrony, the Vision did better even of ventilators that were provided with the NIV software for ICU ventilator. So very good performance. So but you can tell me that valve can completely erase CO2 rebreathing. But again, we are in 2021. I remember that many years ago, another paper by the group of Lofazot stated that we need to work with at least 8 of EPAP to completely clear the CO2 rebreathing. Well, time passed by. Why time passed by? Because the intentional leak in normal interfaces can reach 20 centimeters of water, up to 50 liters per minute of leaks. And this is the reason that led most of the company, they are manufacturing interfaces to decrease the amount of EPAP during bi-level ventilation to 3 centimeters of water. But to explain well, again, this with a nice study, this study has some bias, but it's nice to make an example. You can see the dynamic dead space is a sum of the physiological dead space to the interface and the dead space of the interface. The dead space of the interface in vitro is just the space of the interface that can be filled with water. It is also obvious that this dead space can be reduced once the mask is fit on the patient. But anyway, in the blue column, you can see the dead space, dynamic dead space is very high when you just apply 16 of IPAP. But very strangely, if I use just CPAP 4, EPAP 4, CPAP 4, dead space can be reduced. And if I use 16 and 4, I can switch to the physiological dead space. So I can tell you that in 2001, with the new interface, the problem of the dead space is really negligible. And this is in the nice paper published again 2003, so many years ago. And this was just a bench study that was comparing 3 types of interface, 2 small full face masks and a total face mask. Well, they tried to do this bench study by using a rebriefing, by putting CO2 inside the circuits, and went to see how was the pressure needed to try to erase, to clear the CO2. Very interestingly, they see the amount of pressure needed to clear completely the CO2 and to have more or less the amount of CO2 that they had with a conventional vented full face mask was obtained using few centimeters of water more of pressure. That the take-home message is you are switching from a conventional full face mask to a total face mask. You have to increase the pressure of 2 or 3 centimeters of water. Not only I can tell you and show you why in a few slides, also because to obtain the same performance with more leaks, you have to increase just a bit the pressure applied to the respiratory system. So the final message is you can use a vented mask with negligible rebriefing in 2021. Another good issue is leak compensation. So this not very well known study published by Smith and Nielsen in the European Respiratory Journal in 1996. And there were challenging leaks compensation with volume control ventilation and pressure control ventilation. So you can tell me, everybody knows that pressure control ventilation is able to better compensate for leaks. Everybody knows. But very strangely, this black box indicates the ventilator that did better in terms of leak compensation was the BiPAP STD 30, while in the circle was the NIPI. It was a vented ventilation, was a non-vented valve ventilation. So at that time, nobody was taking care of this, but leak compensation did better with the intentional leaks circuit as the BU60 and the BiPAP Vision, etc. All the ventilators that are working with a vented system. And this was again demonstrated, sorry, the year is missing, this is CHEST 2004, where in terms of compensation, again, the all STD did better, the Puritan vented 7,200, a very powerful ICU ventilator. So anyway, the winner was the intentional leaks configuration. Well, time passed by, and we arrived in 2013. And Annalisa Carlucci and myself in this study were scratching our heads because we were thinking, but when we are using a volume guarantee mode, is this volume guarantee mode perform better if I use an intentional leaks configuration, a vented configuration that is upper configuration, compared to non-vented configuration? So this is a vented, this I applying a leaks right here, and the volume is completely stable. What's happened in non-vented configuration? We did a trick, really, because we started with 8 centimeters of water of IPAP and 4 of PEEP, and then we challenged a tidal volume of 500 milliliters. What's happened? We use an IPAP max of 30, and gradually the ventilator increased the pressure to reach tidal volume of 500 milliliters. But at the time we produced the leaks, incredible, the tidal volume decreased to 200 milliliters while remaining stable on the vented circle. But the reason was because the pneumatograph, the flow sensor of the ventilator was reaching a very high tidal volume. Why? It's very simple. If you look to an ICU ventilator and you see in a contemporary way the inspiratory tidal volume and then expiratory tidal volume, you can see the tidal volume increases while expiratory tidal volume decreases. And because the algorithm is linked to the inspiratory tidal volume, you can see the pressure drops. But for a simple reason, because flow is measured as a delta pressure on resistances. If I decreases resistances, the flow increase, and because tidal volume is flow over the time, I read a higher inspiratory tidal volume, but unfortunately a lower expiratory tidal volume. For example, this is a patient in telemedicine, in a remote control mode from home, and this patient was desaturating, and we didn't understand why. Then we noted the patient was a non-vented ventilation with a valve. Tidal volume was increasing, but as you can see, expiratory minute of ventilation was decreasing. You can see this is a result of the study you saw before. On the right part, you see a vented circuit, and on the left part, you see non-vented circuits. So you can see you have a pressure drop in non-vented configuration because the tidal volume was measured, and instead on the left part where the tidal volume was just estimated, the ventilator with a different algorithm maintain the set pressure. See to the real life. You can see this REM desaturation during rest sleep in again remote control from home. This is non-vented configuration, same ventilator. Okay, I can tell you also the name. We were working with the Puritan Bender 560. We just switched the volume targeted mode from non-vented to vented. I swear there was the same patient the night after. You can see just changing the configuration from non-vented to vented, we were able to maintain the tidal volume without saturation. This is obviously working until the leak capability of the ventilator. Some ventilator is able to compensate until 25 liter of non-intentional leak for overall 50 liter per minute. Other compensate for other value. It depends on the ventilator. So again, in 2013, this paper by author was able that leaks compensation did better with the old vision because they use again the old vision compared to the ICU NIV mode of ICU ventilator. Again, vented configuration was the winner. But I can tell you that all is glittering is gold. United States, they use this expression many times. So we have some drawbacks. One drawback is the oxygen, the concept of oxygen bleeding. This is especially true in a country with low income. You need much more oxygen because you have leaks, intentional leaks, to obtain the same FiO2. The other important issue, you cannot use HME using normal vented mask. With vented mask, it's mandatory to use active humidifier. And again, performance. I told you before that when you switch from a full face mask to a total full face mask, you can lose in performance and you can have also an increase in CO2 rebreathing. Well, you have always to increase a bit the pressure, switching, for example, to 10 to 13, 14 centimeter of water, a few centimeters of water to compensate for the performance of the ventilator. And another important issue, to have a reliable tidal volume, leaks, the intentional leaks should be not random. What does it mean? That if you have a correct intentional leaks, but you have a random non-intentional leak. For example, you have a children, just to make an example very simple. You remove the pacifier and you put the pacifier, remove the pacifier and remove the pacifier. These random leaks can create sometimes a misreading of the tidal volume, the estimation of the tidal volume. So I already told you some word regarding the interface. Just I want to add some important issue. The problem of skin breakdown is not a problem only in the acute setting, but it's also a problem in a home care setting. This is our old paper published more or less 20 years ago. We found that even after 24 hours of ventilation with the mask they were using at that time, we had skin breakdown. But the problem is not completely overcome because even in 2014, this paper by Yakamuti stressed as after a few hours, 26 in this case, they could have, with not proper well-fitted mask, skin breakdown. So what is my recommendation? Because it was completely demonstrated by Fraticelli, by the group of Ambrochard, that all interface in the market, all instrumentarium, those instruments you have, all the armamentarium you have to ventilate the patient is important. I want to stress the real need in the acute setting to use total full face mask, but not only. I explain you why. I want to show one important thing. It was clearly demonstrated that using a total full face mask in this nice paper published by Lemidze, it was the same author that I showed you before regarding the tidal volume. Well, Lemidze was able to demonstrate do not intubate the patient, and early switching from a full face mask to the total full face mask was able to reduce skin breakdown. But not only, because they also used a vented ventilator, a leak ventilator. As interestingly, you can see that the gas exchange was completely maintained also by switching from the full face mask to the total face mask. But I want also to add some more, even not corroborated by randomized control trial. We are using 3 or 4 years in major obese patients weighing up to 340 kilograms. The hybrid mask, I can tell you also the name, the Amara mask from Respironic. This Amara mask, in the same way with the total full face mask, is able to switch the nasal bridge. And by switching the nasal bridge, is able to preserve the skin without any skin breakdown. And there is no way this mask can stand up to 40 centimeters of applied pressure to the airway. Why say 40? It seems unclinical. It's not a joke, because this patient sometimes, because they use a 2-level of an auto CPAP with a pressure support, sometimes the PEEP is able to rise up to 15. If you add 25 of pressure support, pressure is 40 centimeters of water. Just to spend some words on the COVID-19 pandemics, we published this paper with Michel Satwin and Irene Esposito, published in 2020. It is true that we can use a vented mask in not COVID pandemics, not during viral infection. It's also true that we have to absolutely forget this patient during pandemics. We have to switch to other way to use an intentionally system. You can use a non-vented mask. You can use HEPA filter or HME. They have also the capability to work as an IEPA filter. And we can do another thing, because we can also apply on the VU system even an additional HEPA filter plus an HME, even if sometimes you don't need it, but you can need it. But remember that this may reduce the sensitivity of the patient disconnect and sometimes reduce the sensitivity of also the inspiratory trachea. But just I want to show you this paper that was published in the Blue Journal, not in Mickey Mouse, in Blue Journal in 2020. We use even a turbine-driven ventilator with an intentional leaks with helmet ventilation with very good results. It was a pilot study. There was a bench study on the healthy volunteer. We have now results, and that we are going to publish also in real COVID-19 patients. So what's about high flow nasal therapy? You know, some ventilator is provided with high flow. It's not a gadget, absolutely not a gadget. It was clearly demonstrated by Lara Pisani and Stefano Nava that the clearance of carbon dioxide can reach the level of an NIV in COPD patients. So it's a very used tool indeed. And this tool can be used even after NIV. This is a paper that was published by Federico Longini a couple of years ago. So it was a randomized control study where they're going to assess the potentiality compared to conventional oxygen therapy with high flow on respiratory rate and patient comfort after NIV discontinuation. Well, the results were very, very good because compared to oxygen therapy, the gas exchange was not different compared to oxygen therapy, but compared to oxygen therapy, the high flow did better result because was able to reduce the diaphragm contraction and resulted also in patient comfort. But high flow nasal therapy can be used also in the time during the break of an NIV ventilation. This is a work of Giulia Spolettini. It is well known. It was published on Journal of Critical Care in 2018. And the study hypothesis was compared to conventional oxygen therapy, where during NIV break, if high flow would reduce the time on NIV. The result was negative because high flow was not able to reduce the time, but very interestingly, high flow was more comfortable compared to oxygen therapy, as was able to decrease respiratory rate and dyspnea compared to the conventional oxygen therapy. So it did better compared to oxygen therapy. But the most amazing study was conducted in ICU as the result of the combination of high flow and NIV as a complementary therapy in patients at high risk of extubation failure. This study was published in JAMA in 2019 by the group of Armand Thiel with Alexandre Demoule, and the study is amazing because the randomized control trial, more than 300 patients per group, one used high flow nasal therapy alone, and the other group used high flow plus NIV. And the primary outcome of the study was the proportion of patients reintubated at 7 days. So they use high flow nasal therapy alone, and they use NIV plus high flow nasal therapy, and they prefer NIV during nighttime. But the result of the study was amazing. This is the Kaplan-Meier of the number of patients who were reintubated at 7 days. And you can see the amount of patients was much more or less during the combination of high flow plus NIV. So what's my take message? I can state the venti configuration better fit to NIV. I have no doubt it's not only my personal belief, it's also the personal belief of other persons that are involved in this field. Tidal volume estimation is pretty good, and it is comparable to non-ventilated configuration in many conditions. We have to know that high overall leaks may result sometimes in poor ventilator performance. It's going to depend on ventilator capability of leak compensation. Hacking humidifier are mandatory. This is absolutely important to avoid any problem related to mucus plugging, especially in not COVID viral pandemics. An important message, remember, in acute setting, I guess there are not only the possibility to use full face mask, but also hybrid mask. There is no study on hybrid mask, but I guess that is an important message. I strongly believe the hybrid masks are a very important tool. In addition, I want to conclude that high flow nasal therapy is not a gadget when it's coupled in a ventilator using NIV. Thank you very much for your attention.
Thank you, Professor Gregoretti, for your fantastic presentation. According to a high-flow therapy research which was conducted in the US and Europe in 2014, 68% of clinicians reported using both NIV and high-flow therapy on the same acute respiratory failure patient. I couldn't agree more that ventilators equipped with high-flow therapy are less time-consuming and may reduce cost when you need to use both therapies on the same patient. We're now going to turn over to Dr. Javier Sayas Catalan, Dr. Sayas is the head of a mechanical ventilation unit, University Hospital 12, de Octubre, Madrid, Spain.
This next talk is about the use of NIV in acute respiratory failure, about titration and monitoring and setting up an NIV in acute respiratory failure. So we will talk about the differences between the use of NIV in hypoxemic failure versus the use of NIV in hypercapnic failure. And we will talk around the patient case, how and when to start, how to set the pressures, the triggers, how to set the rise time, and when to use humidification. PCO2 is the game changer, and it's the main feature we have to look when thinking about the use of NIV, as it will differentiate between hypercapnic and hypoxemic failure. And they are completely different in terms of, first of all, evidence. We have the highest level of evidence of the usefulness of NIV in acute exacerbation of COPD that occurs with respiratory acidosis, and also useful in obesity, hypoventilation, thoracic wall disease, neuromuscular disease that may have acute failure, and post-extubation failure as a prophylactic measure, and also for weaning from invasive ventilation of COPD patients. So regarding hypoxemic failure, we have moderate levels of evidence of its usefulness in acute cardiogenic pulmonary edema, but we have less level of evidence in pneumonia or severe asthma, or even in COVID-19, where we have indirect data, no randomized controlled trials yet, but they may suggest it may avoid intubation in some patients. This difference regards also between different pathophysiology of the use of NIV and the way the respiratory failure develops. In hypercapnic patients, most of the problems are related to muscle impairment, whether they are related to hyperinflation and diaphragmatic disadvantage due to the increase of end-inspiratory lung volume, or due to the increase of chest wall compliance and impairment of airway resistance. And most of these patients have quite preserved lung compliance. They usually have normal or depressed respiratory drive, and they will respond quite quickly to treatments such as bronchodilators or diuretics, or what we know as medical treatment. In contrast, hypoxemic patients may have a greater impairment of lung compliance and diffusion capacity. So they have a markedly increased respiratory drive, and these conditions will take longer to improve lung mechanics. So you may expect quite a lot more time on NIV than hypercapnic patients. So in hypercapnic patients, one of the main features that account for the development of respiratory failure is the respiratory flow limitation, and due to the loss of elastic recoil that leads to increase in end-inspiratory lung volume, so the patient will breathe closer to total lung capacity, and the diaphragm will have a mechanical disadvantage. As you can see here, this is a patient with COPD breathing in spontaneous breathing at rest, and when the patient starts making exercise, it is quite similar to an exacerbation. He will progressively have air trapping. This respiratory flow does not reach zero, and increase the use of accessory muscles, such as the one you can see here in the parasternal EMG. And NIV may improve this neuroventilatory uncoupling, unloading these muscles, and compensating for that intrinsic PEEP. Regarding hypoxemic respiratory failure, as I say, they have very high respiratory drive, and it can be relieved by increasing pressure support, but this also may lead to an increase in tidal volume over what we know as not being protective ventilation, over 9 or even 10 milliliters per kilogram of weight. We know from the Floralis study that an increase in tidal volume over 9 milliliters may be linked with worse outcomes, and even more in study that take a look at tidal volumes under NIV. A tidal volume over 9.5 milliliters per kilogram may predict failure with a sensitivity of 82% and a specificity of 87%. So you may need to include conscious sedation, especially opioids, but in the ICU setting, it might be more useful, something like propofol, to reduce that high drive. These patients with very high drive, they may need ventilators that can match its inspiratory drive, providing enough flow, enough accelerating flow that matches the patient demands. So unless patient discomfort is very severe, try to use the lowest rise time as possible. You can see here two different ventilators set at the minimum rise time possible with the exact same ventilation parameters. And you can see the differences in the way the rise time increases pressure from EPAP to IPAP. And that leads, as it's very slowly comparing with this one, it will increase the use of inspiratory muscles, while a fastest ventilator will decrease the use of inspiratory muscles and loading them. You can see here, when using a slower rise time, you have an increased use of parasternal muscles, and when you use a fastest rise time, it will decrease the use of these muscles. This is something that we can see quite frequently in patients with severe COVID-19 that underwent non-invasive ventilation. You can see here that there is even a decrease in the pressure due to the inspiratory effort of the patient, and the way that you have two different waves in the flow regarding the one that it's made only by the effort of the patient, and the ventilator will only support him in the last part of the inspiratory cycle. So this may be felt by the patient as if it was hungry for air, and the ventilator does not match that demand. You can see here the same way. You see the peak of the inspiratory flow does not cover, it's earlier than the peak of the pressure in the ventilator. This decrease in the pressure, it's made by the inspiratory effort of the patient, a very intense inspiratory effort. You can see here also in the decrease to trigger the ventilator. And even the patient, you can see here a whole under assistant process where the patient is still exerting some inspiratory demand when the ventilator has just shifted to aspiration. We have taken a look with Manel Luján, and we have some paper that will be, we hope, sent to be published early, where we compare different ventilators and their ability to maintain pressure, to pressurize under different pressure support levels. And we have checked this both in simulator and in some patients. And there is a huge difference between ventilators. As you can see, some home care ventilators are not able to provide enough flow to maintain pressure when we have a very high pressure support levels. You can see here the V60, it's able to maintain the PTP 300 as a marker of capacity of pressurization, comparing with other ventilators that perform also quite well, and some others that they are not able to reach that pressure. In this patient with a V60, you can see how a very intense inspiratory effort decreases the pressure. And when you use a very slow rise time, it will even only reach the inspiratory pressure at the end of the inspiratory cycle. So we have a patient, 65 years old, woman, former smoker with a very high smoking history, with severe obstruction and air trapping and static hyperinflation, with mild hypercapnic, a stable condition that is admitted due to a COVID-19 pneumonia, and she shows a very high respiratory drive using accessory muscles with a marked increase of bad prognosis, such as high D-dimer or high CRP. So NIV started trying to avoid high volumes. Trial of CPAP is required initially, but she needs a low dose of morphine and midazolam due to agitation and tachypnea. You can see here how we started with CPAP and then shifted through the next days to B-level positive pressure, increasing the flow, and with reasonable leak with some high pressures. We use a very high level of PEEP, around 10, with a very low level of pressure support, as she maintained a very high tidal volume, around 600, which was around 8.5 milliliters per kilogram. And we need to start at 100% of FiO2 and then titrate it downward to obtain SpO2 around 88 to 92. The optimal PEEP in COPD may decrease inspiratory effort and may facilitate the triggering of the ventilator, but we have not any tool to calculate intrinsic PEEP and titrate PEEP according to the intrinsic PEEP of the patients. New Trilogy EVO displays some dynamic parameters such as compliance or intrinsic PEEP or plateau pressure, but it's not validated in peer-reviewed journals, but it has been validated internally by Philips, and some physicians are using them to calculate the optimal level of PEEP. As you can see here, you can take a look at dynamic compliance. In my experiences, this is extremely variable, depends on leaks, so I won't recommend to use this as a guide, but it can be a tool that may be useful in the future if it's validated. As I say, a correct level of PEEP will decrease trigger delay and wasted efforts. You can see here a trigger delay. Effort start here, and it's only some milliseconds later where the ventilator recognized the effort, or you can see here some wasted efforts that are not recognized by the ventilator. And this is our patient with a very high drive. You can see how it decreased the pressure in the inspiratory phase, even generating those two modal peak flows. Due to a very intense inspiratory effort, you can see here sometimes even reaches around 1000 milliliters of tidal volume. So we need to increase sedation, decreasing spontaneous breathing at night. You can see here how the patient will start on backup respiratory rate, but she did not tolerate to stop NIV to get some oral feeding. So we changed the ventilator to a V60 plus, where we were able to move between NIV and high flow oxygen therapy, just changing the mode in the ventilator. This patient has COPD. She may need bronchodilators, and there are some chambers that can be adapted, but we use mesh nebulizers online that allow for minimal induced asynchronous. Jet nebulizers may induce asynchronous due to the use of an external flow source, like here. We have published, and we have another paper regarding the asynchronous generation of the use of external flow in a set of different ventilators, and we saw that the use in some ventilators of an external flow may induce auto-trigger or even wasted efforts. How to set the triggers? Well, inspiratory trigger, we will set it as sensitive as needed, but avoiding auto-triggering. And inspiratory trigger, we will set it as a higher percentage of peak flow to achieve inspiratory to expiratory ratio around 1 to 2.5 or 1 to 2.3. When using AutoTrack, it may be useful in the Philips electronic signal to trigger the ventilator. It may be useful in most of the patients with a regular breathing pattern, but some patients may need to shift to flow triggering or even time cycling in some cases. How to monitor? Well, NIV failure can be considered under two different perspectives. If it is an early failure, most of them are a failure of the non-invasive approach. I mean, problems with the mask, with secretions, or you will still have some room for medical treatment to work. So if the patient is intubated, it may not have a very worse prognosis than patients that do not fail to NIV. But when the patients fail, a late failure of NIV can be considered as a late failure of medical treatment without room for optimize. So the mortality in this case, it's very high. For COPD, there have been a lot of works trying to show different predicting scores, such as the one by Confalonieri many years ago. I think it's still a great work, taking a look at different things like a coma scale or respiratory rate or blood gases at the beginning at 2 hours of NIV. And for hypoxemic patients, we have the HACOR index that may predict at 1 hour of NIV the patient that will failure regardless of diagnosis, age, and disease severity. It's a quite interesting score to measure in hypoxemic patients with NIV. Regarding humidification, it has not been established the need of routinary humidification is discussed. In prolonged NIV, it may be advisable. Consider active humidification, but it may have some impact on ventilator performance or in humidification capabilities. There are some recent works regarding changes in pressure support level when using different humidifying circuits. And we even took a look at the ability of maintaining pressure when using domiciliary home care humidifiers. And some of the ventilators will decrease the pressure in a significant way when using external humidifier chambers. Our take-home message will be, for hypercapnic failure, it will be due to an increase of airway resistance or changes in chest wall compliance. There's a high level of efficacy in an NIV approach. It's important to set the optimal level of PEEP to counterbalance intrinsic PEEP, and monitoring improvement will be related to improvements in arterial blood gases and respiratory rate and level of consciousness. For hypoxemic failure, there's lower degree of evidence of usefulness, generally speaking, but for something like acute cardiogenic pulmonary edema, it will have a moderate to high level of usefulness. Usually it's lung compliance, what is the main pathophysiology mechanism, and usually they are needed higher levels of FiO2, and it will usually spend more time on NIV. And a good tool for monitoring will be the HACR score. Choose ventilators that can match high inspiratory drive and consider humidification if long time of NIV is expected. Okay, this next talk, it's about the use of high flow in the acute hypoxemic respiratory failure, how to set up monitoring and titration. So we will take a quick look about indications of pathophysiology, the available devices to deliver high flow, what could be an initial setup, goals of therapy and monitoring regarding especially the ROX index, and how and when to wean from high flow, and other uses of high flow, such as combination with NIV or to use it as an aid to facilitate tracheostomy decannulation. Some of the risks that high flow may suppose. So it is not only another more complex and expensive way to deliver oxygen, but an open system to deliver heated and humidified high flows of a mixture of air and oxygen. And it is effective because it works decreasing rebreathing, washing out what we can call breathed gas from anatomical dead space. And it also matches inspiratory flow demands with an external source of flow, maintaining FiO2 through the whole inspiratory cycle. It generates a mild PEEP effect that could be of interest in some conditions, such as cardiogenic pulmonary edema, decreases work of breathing, generating a deeper and slower breathing pattern, decreases metabolic cost of gas conditioning, and reverses microatelectasis. By the way it works, its main indication is the hypoxemic respiratory failure, especially infectious hypoxemic failure, including COVID-19, or in immunosuppressed patients, such as hematological or solid organ transplantation. Also, it is of great usefulness in the postoperative respiratory failure or to prevent post-extubation respiratory failure. It is not established its role in hypercapnic failure, probably NIV is superior in that setting, or its use in home care, although there are some ongoing studies regarding this use. And also for congestive heart failure, there are some studies that may reflect some utility in this setting. To provide high flow, we need a flow generator that could be a mixture of compressed gas, both oxygen and air, from a wall plug and a flow meter to mix both gases. And then a turbine is another alternative to generate that flow. Anyway, that air should pass through a heater or an humidifier, and it's delivered to the patient through nasal prongs or tracheostomy connector. These are some of the double flow meter mixers that are in the market, but you need a wall source for oxygen and air. They will pass through a heater chamber and an humidifier, and through a heated circuit, it will be delivered to the patient. There are some devices that they do not need an air source. It will work through a venturi system with only an oxygen flow, but they have some disadvantages, such as they are quite more noisy. And turbine-based devices could be divided in dedicated high-flow devices, as the well-known Airvo or TNI or some other brands, or multi-mode devices, which is the current cutting-edge technology that it's being incorporated in different devices. They only need to change the turbine behavior instead of pressure control, being flow control, and allows for sequential or combined treatment with only one device. For example, to allow some pauses of NIV for feeding, you can use the same ventilator, changing from NIV to high flow. And currently, there are some manufacturers that have this kind of technology, such as Philips with the V60 Plus, but Breas or Lovenstein, they are incorporating this in their devices. To start, you will need to prepare all you may need to check the oxygen supply, the connectors, the correct fitting of the heater chamber in the heated plate. This is very important to avoid problems with connection or overheating. To check the water, preferably in a plastic bag. Take care of any electrical wiring conditions. We are playing with an open source of high flow oxygen. Choose the appropriate nasal prongs. Try to avoid collapsing the nasal prongs in the nostrils of the patient. You can see that if that happens, you won't be able to deliver the set flow, and explain it to the patient, urging him to breathe through the nose with the mouth closed. We usually start with a minimum of 40 liters per minute. Under that, effects are very discreet and more useful in long-term use rather than in the acute care. But we usually work with 50 or even 60 liters per minute. Temperature, as most of the studies started with 37 degrees, in our experience, patient will not tolerate so high temperature. So we usually use 31 to 34 degrees. And FiO2, we start with the highest needed, the same as the patient have in spontaneous breathing, and then titrate according to your oxygen saturation goal. You must take care, as I said, with some prongs that may be collapsed if not correctly fitted. In this case, the device won't be able to provide the set flow, and in some cases it may stop even. So try to check that they are perfectly centered and totally expanded. The goals of the therapy are avoiding intubation and decreasing mortality, and it should be considered, as with any other non-invasive support, as a bridge to let the medical treatment work. Intermediate goals will be improve the breathing pattern, improve oxygenation, and all of this with a good tolerance. So a close monitoring is always advised, and the delay in intubation may increase mortality. As a score for this monitoring, some Spanish colleagues developed the ROX index, which is the ratio of SpO2, FiO2 to respiratory rate. It was initially developed in hypoxemic pneumonia patients, but it has been widely used also in COVID-19 or in postoperative care. It is pretty good at predicting the patients who will perform well. If you have ROX index after 12 hours of high flow over 4.8, it is not likely that you will require intubation. As I say, we will start with FiO2 of 100 and high flow, and then within 1 hour monitoring with the target SpO2, titrate downwards the FiO2 until you reach your target, and you can check for the flow needed to maintain less than 25 breaths per minute. When the condition that lead the patient to the respiratory failure improves, it may be time to wean from nasal high flow, and then you will start decreasing FiO2, and when you reach an FiO2 below 40%, you may start decreasing flow rate by 5 liters per minute. And when you reach a flow rate under 15 liters per minute with FiO2 under 40%, you can stop high flow and then change to conventional treatment. When you use it combined with NIV, it has demonstrated a better outcome in post-extubation failure patients, especially in those who are hypercapnic, reflecting that probably NIV is the way to go in patients with hypercapnia, but also in patients non-hypercapnic, high flow combined with non-invasive ventilation avoid more intubations that had high flow alone. It is pretty useful to allow for disconnection from NIV. This is a COPD patient with under NIV. You can see here the pressure, the flow, the ultrasound of the diaphragm and the parasternal and surface diaphragmatic EMG. And you can see that it is pretty well supported with the NIV, with a small movement of the diaphragm. But when we try to set him in spontaneous breathing, you may see a huge increase in muscular activity and in the swings that the diaphragm has to perform in order to maintain a correct ventilation. If we leave him that way, it will fatigue and we will have to start soon NIV. So once again, if we try to stop NIV and put the patient on high flow, we will find a medium use of the muscles and a medium displacement of the diaphragm that allow the patient to resume NIV for feeding or for speech or just to take care of his skin. It has been also used to facilitate tracheostomy decannulation. In a recent paper by Gonzalo Hernandez, who is a colleague from Spain, he demonstrated that it was faster, the process of decannulation, if you use a sequential use of high flow, first through the tracheostomy and then capping the tracheostomy and using it through nasal prongs. And that's the way we use it here in almost all the post-ICU COVID patients who are in our weaning unit with tracheostomy, and then we cap the tracheostomy and use the high flow through the nasal prongs. There are some risks of high flow. Probably the most important risk is delay and unneeded intubation from mechanical ventilation. We are quite good at predicting the one who may be successful. We're quite worse detecting that won't be successful, and prognosis of a delayed intubation, it is really worse than in patients who have direct intubation. Another risk is they are devices that may have high oxygen consumption, and in a COVID outbreak, it has been an issue here in some hospitals in Spain, but also in UK, there are some news facing oxygen shortage in some areas. And of course, it's an aerosol generating device that may have a potential role in healthcare workers' infection. There are some concerns about generating small size particles of aerosols. We have multiple bench studies, but in studies in real life, there was no increase in healthcare worker infections when adequate protective gear, such as FPP3 mask or gowns or glasses were used. And a surgical mask over the prongs may reduce aerosols. And there is another frequently underlooked risk, such as the potential risk of fire hazard. We are in the same place with comburents, such as oxygen-enriched atmospheres, with combustible materials, such as plastic or dressing or clothing. And if you have an ignition source, that could be an electrical spark, smoking, or, for example, an electric scalpel, you can have a fire hazard problem. It has been reported, for example, in Spain, a patient died after started smoking under a high flow oxygen and it got burned. But also in Turkey recently, there have been several patients killed in a massive fire in ICU. Or here in Mumbai, there is a video where a high flow caught fire spontaneously, thus producing a very risky situation. So it should be addressed, that risk. To finish, our take-home messages. High flow is a useful tool in managing hypoxemic respiratory failure. Try to start with high flows with a temperature between 31 to 34 degrees and the FiO2 needed to reach your SpO2 target. Titrate downwards FiO2 as soon as possible and then decrease flow as patient condition improves and you are trying to wean from high flow. As always, a close monitoring, including the use of the ROX index, is mandatory and can be combined with NIV. Thank you.
Thank you, Dr. Sayas, for your excellent talks. The case study with NIV and high flow therapy again shows the importance of choosing the right ventilator for optimal therapy. We will now move to a Q&A session.
I think there are some different questions on when to use CPAP or BPAP, and I think we can discuss it. Before that, I have one question for Professor Gregoretti. regarding the use of the helmet with the V60 Plus. We have some different approaches between colleagues on where to set up the pressure line, if to set up direct connected to the helmet, how it will perform in that case. We have more experience using the Trilogy Evo or other vents that they do not have pressure line, a proximal pressure line. And I would like to know the opinion of Professor Gregoretti.
We discussed this issue many times with Manuel Lujan, and we published the setup recently in the Blue Journal and before on a scientific report, Journal of Nature. We have a large experience with the V60 because we have just finished up a study in Turin where we treated more than 50 or 60 patients with the V60 in intentional leak configuration. And very interestingly, we have some news, a matter of patent, so I can release this news right now. But we always use an intentional leak configuration. That means we use the V60 circuits, but we close obviously the leaks that was proximal to the helmet with using another circuit, and we measure pressure close to the helmet as in the original circuits of the V60. So practically speaking, we have a single limb with the pressure measurement close to the helmet, okay, close to the HEPA filter. And then we had a leaks. There was a 6 millimeter tube connector on the expiratory port that was connected to another HEPA filter. So the system was almost closed, but interestingly, before starting ventilation, we performed what we did the leak test. So if you close the expiratory leaks, the expiratory intentional leaks, and you go to measure the overall leaks measured by the V60, you can see whether or not your system is completely sealed. This is very important because the paper is entitled Performance and Safety for Using a New Helmet Configuration for COVID-19 Pandemics. So I strongly believe that in this way we can produce genuine CPAP. At the same time, we have other interesting issues that Manuel knows, but I cannot release right now because I told you it was a matter of patent. The data we collected are thousands of data, and I can tell you that the device was very well worked by the patient. The only thing that we didn't do was using an active humidifier. We prefer not using active humidifier, even because a part of the air was coming from room air. So the air that was reaching the patient was not without humidity, as using completely dry air from the usual hospital feeding system, because oxygen was coming from the oxygen pipe, but air was coming from the room air. And this is why we tested also the configuration with other ventilators than V60. We used the Evo, we used the Astral configuration, and I tell you that in our opinion that was the more convenient configuration that did the better benefit also in terms of patient ventilation interaction. We replaced the conventional single limbs of the V60, or what is usually furnished with the ventilator. We use a conventional single limb. We use a connector to use the pressure transducer close to the helmet. Then they produce the intentional leaks as in Blue Journal configuration using a 6 millimeter tube connector on the expiratory outlet of the helmet. In this way, we reached up to 60, 70, depending on PEEP pressure of continuous flow inside the helmet. With 14, we reached about 65 liters, 70 liters per minute of fresh gases.
I think that's the key. I mean, to take a look when you're using the helmet at the inspiratory flow that your device is displaying, and to ensure that there is a minimum of 50 or even 60 liters per minute that will ensure that there is a complete renewal of the gas and to avoid rebreathing.
Yes. Absolutely. We had, as we explained in the Blue Journal, using the Evo, with a patch inside. We were able also to measure tidal volume. I tell you, it's a matter of patents right now, not unfortunately with Philips. We were able to use monitoring of tidal volume during helmet ventilation anytime. What is also amazing that we perform what we call a leak test at the very beginning of the ventilation. So we close with a finger the intentional leaks for a few seconds. And in this way, we can see if the system was completely sealed. So this is the reason, because the title of the new paper is Performance and Safety of Using a New Configuration for Helmet Ventilation, because leaks are very important in COVID. So I guess that having a completely sealing system without any leaks is very important. In addition, this is also the reason because we didn't use active humidification, even when we were using a helmet for more days, because frankly speaking, the room that the patient was getting was not completely dry, because as you know, V60 suck the part of the air from the room air. So the room air is not completely dry. We had no problem of mucus plugging at all. We use other testing with, as I told you, with V60, Evo, even with Astral. And we use also other configuration. For example, I'll tell you the flu, we use even a double limb configuration using, for example, the Astral. But in this case, as you told you, we use 5 of pressure support in order to increase the flow inside the helmet. You can use with a double limb conventional CPAP. It was well demonstrated by Tacconi many years ago, because the flow inside the helmet with conventional CPAP double limb circuit is 20 liters per minute, even less. But if you add 5 of pressure support, just 5, you can reach up to 80 liters per minute of fresh air inside the helmet. So there are many tricks and traps of using a helmet. I guess that the simple one, using the configuration we use in the Blue Journal with the 6 millimeter tube as the intentional leaks, the V60 as to drive the ventilator. Somebody asked me if C-Flex on the V60 can interfere with the estimation of tidal volume. I don't guess. We didn't any experimentals on this, but according to what the group or your group and Lucian group, I guess that the engineer of Ibis were smart enough in order to make some correction to the patch when you correct the expiratory flow in order to reach a reliable tidal volume, I guess. The other question is if you use in post-COVID AVAPs. I mean, you can use whatever you want as a mode of ventilation. I guess that AVAPs is an interesting mode to work. We don't choose AVAPs from the very beginning. We choose AVAPs just when we need it. I can tell you, just yesterday, I was trying AVAPs with our patient is a patient affected by very restricted chest disorders, and that was ventilated so far with full face mask or an Amara mask. We decided to switch the patient with a nasal mask, and we keep using AVAPs. I was very surprised. AVAPs was working perfectly even with a nasal mode, and the patient was able to feed himself with a nasal mask. He was so happy after many years. The people was pushing him to using a full face on his face and put his in oxygen with a lot of effort for the meals.
Some other questions I will try to ask right now. There's a question about the use of high flow for, I think it's tuberculosis patients with hypoxemic failure. Well, there has been a lot of controversial on the use of high flow as a way to veiculate highly possible infectious particles, especially with viruses and especially in the COVID-19 pandemic. I guess that the size of the particles that may produce a high flow, especially if you put a surgical mask over the nasal prongs, they do not may have such enough size to veiculate a high amount of tuberculosis bacilli. So I think it has probably more risk to put a high flow in a patient with active high viral load than in a patient with tuberculosis that should be placed in an isolated room, preferably with negative pressure in the room. So as I have not precluded the use of high flow in COVID-19 with adequate protection, I will probably do not preclude the use of high flow for tuberculosis patients.
Thank you, Professor Gregoretti and Dr. Sayas, for answering those questions and for the great presentation. It was a pleasure to have you with us. On behalf of Philips and our presenters, thank you again for joining us today. We hope you have enjoyed this webinar.